All right, welcome to another meeting of the Informed Prostate Cancer Support Group. Thank you everyone for attending today. I'd like to extend a special thank you to Sanford Burnham Prebys Medical Discovery Institute for the use of their auditorium. I'll mention right now, as well as later on, our May meeting next month is canceled. Sanford Burnham is renovating this space, so when we get back in here in June, it's going to be all different, nice new comfy chairs, new carpets, and so forth. So, what's that?
We'll get back in July.
Oh, okay, back in July.
Yeah, we're skipping June, right?
I thought we were doing that as pre-recorded and then showing it here. Tell you what, everybody, keep your eye on the website. The May meeting is definitely canceled, and June is TBD. All right. Oh, not sure why I'm not seeing that here. The principals of our organization are Bill Lewis, our president, who also does the newsletter summaries. Gene Van Vliet, our director and treasurer. He could not be here today. Steve Pendergast, who I also think is missing today. He is the secretary and does the newsletters. Bill Manning, our director and videographer, although for today we have a stand-in, Patrick, who's been nice enough to help us out. There's myself, Aaron Lamb, director and facilitator of the meetings, John Tassi, our webmaster, Bill Bailey, our librarian, and of course there's you, 900 members more than 900 members, but all of you are very important to this organization as well. How many newcomers do we have? How many people are here for the very first time today? All right, excellent. We've got 3. So hopefully you each received the newcomer packet. I know at least you two did. Did you get the newcomer packet? Excellent. Oh, that looks like the new newsletter. So did somebody at the door give you a newcomer packet? It should have a cover sheet to fill out with all of your contact information. I think somebody's getting one for you right now. This information kit is going to include articles and booklets, pointers to articles and booklets that can help answer all of your questions. Please do fill out that cover sheet and return it either to Bill or to myself. That will get you either Bill or Gene calling you this coming week to basically, discuss your current situation, see what kind of information you might be looking for, asking you how the organization can best help you. So it's it's very useful. And that will also get you on our mailing list to get the newsletters emailed to you, the announcements of future meetings, etc. And on the mention of the newsletters, yes, we do offer them by way of the website that you can download. You can get them by email as well, and we do still have a few people that are receiving them by mail. If you want to receive them by mail, please do see Bill or myself or Gene email by way of the support group, the info email, and let us know, because we can send those to you. And of course, there's a whole slew of printouts of the prior newsletters available on the first table just outside the door here. All right, so we've seen who's here for the first time. Who's been recently diagnosed with prostate cancer? One new guy, yes. This is this all hands welcome survey is very useful. Again, kind of talking to you new folks here. If you are considering some type of treatment in the near future and have questions, the people that are going to raise their hands when answering these questions are people that are essentially experts from the customer side of things. And so whatever questions you might have, those people that raise their hands are great wealths of information for helping you get those answers. And I guess that applies a little bit more to the next slide, as you'll see. So who's had prostate cancer for less than 1 year? So a few of us here, 1 to 4 years. Several more, 5 to 10 years. All right, quite a few. 11 to 15 years, still quite a few, and longer. So who thinks they have the longest? Shout out. 18. 18. Who is higher than 18? 25. 25, all right. All right. So the key thing to take away from that for you newcomers is that, this is not a life sentence. Prostate cancer is 2 words. And so you have a long life ahead of you, a lot of time ahead of you. Now for the treatment summary. Who has been on active surveillance? All right. Who has had surgery? Radiation? ADT and hormone therapy? Yeah, quite a few of us. Who's had chemotherapy? New treatments, whether it's focal or immunotherapy, Xofigo, Pluvicto. An expert here. How many have had recurrence where the cancer has come back? That's a big reason why some of us that have had prostate cancer for so long are back here, is especially to figure out who is undecided on their future treatment. Here to answer those questions. Please note that we are on Instagram. There's the address right there. Please do follow us. Click on some of the posts and like them. That helps get these advertisements and information slides in front of more eyes to get our message out there. And we are also on YouTube. All of our past meetings are recorded and available for you to review on YouTube. They are even edited to have chapter marks so you can skip ahead and not have to listen to me and go directly to whoever we were interviewing for that particular day. So please do check those out, especially if you miss a meeting. We do also have a new Instagram video. And I will apologize, this is actually our old Instagram video. We do have a new one now that has a speaker actually reading off all of the information as it is displayed on the screen. So I will have that updated for a future meeting. And to tell you a little bit more about our support to you, we have our website. The address is shown there. On that, you can find a huge amount of information, all the old newsletter links. We have YouTube, as we just saw a slide on that. The newsletter, for those of you who have not checked it out yet, it contains a very well-written summary of the prior month's meeting. Excellent to read through and recap what you might have missed or forgotten. Bill Lewis and Steve Pendergast do a fantastic job of putting that together. The newsletter will also contain an announcement about the upcoming meeting, and it frequently has a number of medical journal articles of the latest research that may be of interest. We, of course, usually meet on the 3rd Saturday of every month, not in December and not in May this time. And we do have hotline numbers that you can call if you need some questions answered before our next meeting. These numbers are for Jean and Bill, and they are also available on the website. Other support to you are in the way of a very low-cost PSA test by Ulta. There's also the Promise free, no-cost germline DNA saliva test that you can get. And locally here, the YMCA Livestrong Prostate Cancer Therapy Exercise Program is also excellent. I seem to recall that it is a free program for people undergoing ADT. And as we all know, those of us who are on ADT, it's incredibly important to be in the gym working out every day if you can. And we do need volunteers. We need people to suggest and recruit new speakers and share your experience. We do have a roundtable coming up. It's going to include Malcolm talking about his experience. That'll be in July. I think Bill already has 2 more people lined up for July, but we are always interested in lining up new members to share their experience. So please do contact us via the website or Bill or Jean's phone numbers to let us know, or even, talk to us today. And I am looking for somebody as a backup meeting facilitator for me. I'm actually going to be on vacation in June, so if we are having the June meeting, I would love to have somebody that can stand in for me. If you're willing to do that, please let me know. Now, our support group purpose is we share patient-focused experience on becoming your own case manager through informing, networking, and caring. We are a group of experienced participants, but we are not medical professionals, and any sharing by any one of our group may not be a substitute for your medical counsel. And we do need your support. Mike, could you pass around the baskets? We are a 501c3 nonprofit organization, so all of your donations are tax deductible. There's no medical or religious affiliations. Our largest costs are in the way of the website, advertising, and mailings. Please do make a donation. Think about the amount of money that you spend on the doctors and the amount of time, the limited amount of time that you get to ask them questions versus the wealth of information that you do get from this group. So I please hope that you're generous in giving us a donation so that we can continue the meetings, the websites, the videos, everything that makes this group so useful to people, not just not just in San Diego, but across the country and even around the world. So if you can't make a donation today, you can do it online via PayPal on our website. You can also send a check to the address that you see here. Jean, our treasurer, frequently does get checks, sometimes even from estates and so forth that set up giving ahead of time. It is all very much appreciated. For our upcoming meeting in June, which again, please watch the website to know whether or not we're going to be meeting here or if this is going to be more of a virtual meeting. We're going to have Dr. Emily Wegg of the University of Washington Radiation Oncology give a talk on flash radiation, which is, my understanding is an extremely high dose of radiation, obviously not given as frequently as the SBRT or IMRT that we're more familiar with. And once again, remember that our May meeting is canceled. We will have that doctor back at a later time. It was going to be one of the Sanford Burnham Prebys doctors who's actually going to give a nice presentation. However, and before I announce today's meeting, yes, many of you were likely expecting to see Dr. Lamb here today. Unfortunately, he did have to cancel, and I wanted to let you know all of what he told us. He said, due to some personal issues, I will not be able to lecture at the April meeting and for the foreseeable future. Sorry, guys. So that's all I know. He's taking a step back from even his practice for personal reasons, and we wish him the best. We'll certainly miss his presentations that he was giving to us annually. However, we are lucky enough to have Dr. Kipper back for a presentation on personal experiences of prostate cancer patients. And for those of us that saw Dr. Kipper's presentation on PET CTs, you know he is quite the expert. So this is a second chance to get a wealth of information from Dr. Kipper. So with that, let me switch over to your presentation, and I think you are all set. Thank you.
Well, good morning again. It's nice to see you all. I was very happy to step in for Rich Lamb, as I had this particular Saturday free, the only one this month, but it happened to work out just fine. I can tell you didn't do any advertising because I see a couple people back, which would be very unusual after having been here with me before. But what I thought I would share with you is some information I've given a couple of times to other groups, which really fits best with your group, and that is the journey of a patient with prostate cancer. Now, you're going to know a lot of this stuff, but there'll be something new for every single one of you. And for those of you who see some redundancy in what you know and what I'm going to say, I don't think it ever hurts to hear it again, and I've tried to put it into an orderly fashion so we can follow our patient from diagnosis through most of the therapies he will be exposed to. We have one gentleman here who has just been diagnosed, and if all the rest of you want to leave and I just speak with him, that's fine too. But for those of you who have a little time to spend with us, I hope you learn something and I hope you enjoy what we're going to cover. And I call this a patient's journey with prostate cancer. This will be a generic patient. We'll name him Mr. Jones. Now, my experience to be able to talk to you is that I've had a fair amount of experience in the field of prostate cancer and imaging, primarily imaging over the decades, but I did work for 8 years in the Advanced Prostate Cancer Center in Mira Mesa, and I have, it's always been my most favorite imaging area as prostate cancer, and have been working in the field for a number of years. The focus will be the perspective of the patient. That means all of you. What do you see as you go through the experience of being told that you have prostate cancer, then to evaluating your various options along the way? The good news is nobody here is going to be exposed to all of these options. So many of them will never even be brought up in your discussions. But that's okay. I mean, you'll just kind of have it as background information. And there's a second reason for me showing all of these various options, and that is to let you know there is so much that can be done no matter what stage of prostate cancer you have. It really all goes back about 20 years ago. That's when chemotherapy first came on the scene for prostate cancer, and that was one of the very first treatments we had beside ADT and then primary treatment with radiation or surgery. And we have at least 40 new treatments since that time, so I don't need to tell you how many more are going to come along in our lifetimes because the world is just exploding with various options. Now, I always talk to the patients and tell them the reason there are 40 treatments is we don't have the one single magic bullet that will take care of everything like we have, for example, for testicular cancer and certain types of leukemia and whatever. But as soon as that comes along, all these things we talk about now will be passé, and I know we're all waiting for that day. And a lot of time and energy and brain power is going into figuring out what the best agents are. I'll address the many aspects of prostate cancer. There are complexities. There is courage involved on the part of all of the folks who go through the prostate cancer as well as their family. There's reasons for optimism, which I'll share with you, and we're going to kind of characterize these treatments. My background is in internal medicine, endocrinology, and nuclear medicine, so that I have experience coming at it from a medical standpoint, not necessarily a surgical standpoint. And one of my interests has always been oncology and quality of life, and I feel that's at least as important as quantity of life. So I have a little bit of a different perspective with my patients, and that is, how do we make them as whole as possible for as long as possible? My greatest privilege, my greatest pleasure in all the years I've been in medicine has been working with the patients and their families. I truly do consider it a privilege. And in the setting of prostate cancer, I have the opportunity to work with not only the patient, but with their family and their other physicians. Now, there is a little quiz you need to take before I allow you to continue with this talk. If you do not pass, thank you very much, but you probably should leave. You're on the honor system. You only have to get 1 out of the 3 right. Question number 1 is, what is a terminal illness? and that's when someone is sick at the airport. Number 2 is, what is the fibula? And that's a small lie. And lastly, how are the main 20 parts of the body characterized? For example, the abdomen, how do we characterize that? And the answer is the body consists of 3 parts: the brainium, the borax, and the abdominal cavity. The brainium contains the brain, the borax contains the heart and lungs, and the abdominal cavity contains the 5 bowels, A, E, I, O, and U. So I'm going to assume, if you all remain seated, that you either were already asleep or didn't get any of these right. One thing for me is I have some loves in life. Among others is my dog, but also I've always had a love of music. And there was a song from many years ago that kind of guided me in my journey through medicine. It's really true. I love the song. I love what she sang. It was written and sung by Carole King. She put out an album that sold gazillions years ago for all of us. We remembered it probably. It was called Tapestry. And the main song, Tapestry, contained these words: my life has been a tapestry of rich and royal hue, an everlasting vision of the ever-changing view. And the last line is what got me, and that is, things are always changing. We're always getting better. Sometimes we take a step back, but we rely on our past experience, and we can look forward to there being changes. And as I said, music, very important to me. Now, let's look at prostate cancer and get started. On the left, you see a drawing, a kind of a cartoonish drawing of where the prostate sits, which is just beneath and behind the bladder and just in front of the rectum. So a lot of times when the doctor is telling you that your prostate cancer has spread to the rectal area, you can see how that can happen, because the prostate is very close to the rectum. And if it hits the rectum, that's going to change everything that they're going to want to do with you. So that's one of the things we learn with the MRI that we obtain, and that is, does the prostate cancer touch the rectum? The other areas that are important, you can see the one in purple there that says the seminal vesicle. That's critical to how we stage our patient and what we recommend. And the seminal vesicle all by itself is what determines whether someone has a regular prostatectomy or a radical prostatectomy. So any of you that had just a prostatectomy, the seminal vesicles were left in place. If your doctor writes down in your record that you had a radical prostatectomy, that means they took the seminal vesicles. So most of us have had radical prostatectomies where the seminal vesicles have been removed, and they change treatment if they're involved with the tumor. The other anatomic sites are not really that critical to what we're talking about today. Now, here are some of the historical milestones in the course of prostate cancer that began way back in 1853. That's when the very first case of prostate cancer was described. It was in England. I guess we're coming up on 200 years now since the first one was described. Early in the 20th century, most men died within 1 to 2 years of diagnosis. So different than where we are now. Nobody dies that quickly with prostate cancer unless for some reasons often beyond their control that it's been completely ignored. So the good news is we've come an awful long way since we first described prostate cancer. By the mid-1940s, metastatic prostate cancer was found to respond to androgen deprivation, the Lupron or Firmagon, or now even Orgovyx, that all of you are probably on. Treatment in the beginning included prostatectomy to remove the gland, or medical castration, either with removal of the testes or putting the gentleman on estrogen, on female hormones. Just an idea of what the early surgeries looked like. Early advances of treatment. Now, what happened here? We lost something. Okay, hormonal manipulation is the suppression of testosterone, and that resulted in significant prolongation of patient survival, not just measured in months, but in years and in decades. Okay, so that was a very fortuitous discovery and has been the mainstay of so many of our patients with prostate cancer. And the first drug to show increased survival was Taxotere or docetaxel, and that had actually already been around for a short period of time, and the gals were getting it for ovarian cancer. And then it was found that it worked as well in men for prostate cancer. This drug, as I told you, was approved by the FDA now 20 years ago. Our patient, and we'll call him Mr. Jones, we're going to explore recent advances in the diagnosis, treatment, and typical experience with prostate cancer. Once diagnosed with cancer, he will begin a potentially complex journey of life-altering events or something very simple. It might just be the prostatectomy and that's the end of the story. It might be radiation and that's the end of the story. It might be that type of primary therapy, one of those two, and then maybe a little ADT. But there are some of you who will undergo additional treatments in time, and we're going to kind of focus on those as well, just so you can say you've heard that there are a lot of options, and be sure you're armed with that information when you meet with your healthcare team. Mr. Jones will not begin his journey alone. His universe of support, and some of you know this, may include many others, including his family, friends, primary care physician, urologist, medical oncologist, radiation oncologist, and even the nuclear medicine physician. Many men will also add a prostate cancer group, like we're doing here, spiritual guidance, an alternative medicine practitioner, and even a geneticist. So you see there are lots of options for medical care. Everybody's situation is different. Some men use all these avenues, some use just one or two. Diagnosis, typically our patient is initially diagnosed, now we're looking at Mr. Jones at the very beginning of his journey, because of an elevated PSA. So everybody still wants to know, what's an elevated PSA? Well, for so many years, we said that a PSA greater than 4 was of concern and we needed to evaluate it. But that number is quite variable. It depends on where you were 2 years ago, how fast it's reached whatever level it's at, what the family history is, are there symptoms? In other words, 4 is a good number to remember, but that's not the case in an individual patient. And as I've told you in prior talks I give here, that I treat every patient as if they're the only patient I have. And it doesn't matter if the average number is 7.2, our patient is one patient, not the average, and that's who we address. And that's what a good physician should do, is view a patient in that vein. PSA is a protein that's made in the prostate gland. It rises in men with prostate cancer, but can also rise for a number of other reasons. And again, a lot of you are aware of this. It can rise in just enlargement of the prostate gland or benign prostatic hyperplasia, and it can arise in infection. It can also arise based on activity and exercise. If you're riding a bike every day and you come in and get a PSA level, it can be elevated because there's a lot of up and down force against the prostate, which can release PSA. It could arise if you had sexual relations the night before or 2 nights before. So there are a lot of benign reasons why the PSA can go up, and we don't get overly concerned when we see a barely elevated PSA. The most appropriate first test is a repeat of the PSA, making sure that you don't do some of the things we just talked about. This can be followed by a digital rectal examination and ultimately a biopsy of the prostate gland. And now perhaps for the first time, Mr. Jones is forced to consider the C word, cancer, because with an elevated PSA and his doctor saying we need to do some additional tests, it's not because they're looking for something minor, it's that they're looking, is there a prostate cancer? Because if it's there, hopefully it's early and hopefully we can take care of it. The elevated PSA reading and the digital rectal exam can be very stressful, not just for the patient, but for the family as well. Everybody's concerned about you, as you would be about other members of your family. So let's not belittle the fact that an elevated PSA has been discovered. It is stressful on the patient and the family. Fortunately, the digital rectal examination has been perfected in animals, and it's been marketed to the public, and the marketing it uses athletes. And perfecting and marketing the digital rectal exam kind of goes along this line. Perfecting the technique. There was a TV show many, many years ago called Wild Kingdom with Marlon Perkins, and he had an assistant named Jim. And every time there was something difficult to be done to an animal, like doing a prostate exam on a lion, Marlon Perkins would say, my associate Jim is going to show you the technique for performing this examination. So if you remember the show, you remember that Jim was always doing the strangest thing. Jim's going to remove the second egg from that eagle's nest, or whatever he had to do. And Marlon Perkins would sit back narrating and staying far away from the danger. So that's how we performed the technique, and we used animals. And then when we marketed with athletes, that gets to men. There's no question about it. And here's an example of marketing it through soccer players, where a prostate exam was shown at halftime of this particular match. Now, about this time, imaging begins to play a role for the patient, okay? The patient has had a digital rectal exam, may have had a biopsy, but may have been asked to have an MRI of the prostate even before a biopsy. That's very common. So imaging now gets into the picture. And on your left is the ultrasound, which is the mainstay of imaging initially and allows us to do a biopsy of the prostate. And an MRI is a wonderful test that allows us to look at the soft tissues of the prostate and around the prostate. And on your left is the ultrasound with the arrows pointing to a black area there, a circular area, and that's a prostate cancer where there are no echoes in there. It's just a blank because the echoes don't hit something and then come back at you. It just goes right through. And on the right, you see that white area. That's the prostate cancer on the right side of this patient. So both of these tests, excellent tests early on, and we now have perfected the technique of putting those two tests together so that the biopsy is much more accurate, because the two together will tell the urologist which areas in the prostate are most likely to harbor prostate cancer. So yes, we do random biopsies still, but we now can do focused biopsies with the combination of ultrasound and MRI. And I'm sure some of you, and maybe our newest patient, when he had his biopsy, had it done under the fused images of the ultrasound and MRI. So a biopsy is recommended to Mr. Jones, okay? His PSA is high enough, the doctor is worried, and a probe is placed through the rectum that touches the prostate and allows them to do their biopsies. They call them cores as they take out pieces of the prostate. Now, the biopsies can be done randomly or guided by imaging. Typically 12 cores are taken, but there may be more, there may be less. And the prostate is not that huge a gland. If you take 12 cores out, take a lot of the prostate out with you, you've done most of the surgery that the patient needs, but we usually do 12 cores. You may be told the biopsy will feel like a rubber band snapping, okay? And whatever marketing person came up with that idea, I guess we got to give them credit until they start doing your biopsy when you feel like each time they take a core, you're being shot from the inside. So I don't buy the rubber band snapping analogy. The area can be numbed with local anesthetic, but yes, this means more shots. So most people don't do anesthetic injections because it's really not necessary. There may be some discomfort, as I mentioned, and there might be bleeding for a few days after the biopsy, but really that's it. There are not too many other complications. They do put you on antibiotics just to prevent an infection taking place. So that's kind of a prophylactic use of the antibiotic to make sure no infection occurs. And all of you have been through that who have had the prostate cancer. Now, once the biopsy comes back, we have a report that tells us where Mr. Jones is. And if you look at the Gleason pattern score, they give you two numbers between 1 and 5. We add them together and we get your Gleason score. The first number is referenced to the cell that is the most common in the biopsy. The second number is the second most common cell in the biopsy, and each one gets assigned their own number from 1 to 5. If the pathologist looks at it under the microscope and all the cells look absolutely normal in that group, he would say, well, that's a 1. And then if he looks at the other second most common cell and he thinks, well, it's like a 2. There's a little bit of change, but nothing major. You wind up with a 3. Well, these days now we only have 6 through 10, okay? If someone reports you as having a Gleason 5 or even lower, it's probably a biopsy from long ago. We just don't do that anymore. So everybody starts either with a 6, 7, 8, 9, or 10. The lower your biopsy score, the less aggressive your tumor. So the best you can have is a 6, and the highest grade or the most aggressive potential is a 10, and that's how we arrive at that. Now, it was not named after Jackie Gleason, actually. It was named after Donald Gleason, who's a pathologist at the VA hospital in Minnesota, and he came up with the pattern. I always like this cartoon of Alice up on the moon. So our journey begins in earnest now. Okay, we have our diagnosis. Mr. Jones has prostate cancer. He must now deal with an overwhelming amount of information. There'll be more testing. We're going to add more members to his medical team. He's going to go through the realization that he's really now in a battle with cancer. Okay, he heard the C word for the first time a couple weeks ago. Now the doctor says he has it. So that's our new position as we're moving along this journey. And fortunately or unfortunately, he is not alone. These are the statistics in the United States for this year. The projected number of prostate cancers up to around 300,000 now. The number of deaths, thankfully, has remained really relatively stable for a long time. And you'd say, well, I'd really like to see the number of deaths go down, wouldn't I? Well, the answer is they go down relatively because it wasn't too many years ago when the average number of cases was 250,000. So with 50,000 new cases but the same number of deaths, we're making progress. Okay, we're getting there. Now, obviously, we want to get that second number down to 0. And we'd like to get the first number down, but we still haven't identified the major causes of prostate cancer with very few exceptions. Now, possibilities for Mr. Jones and his medical team at this point would include his primary care physician, his urologist, his medical oncologist, are based in part on staging, finding out where it is at that point in time. So the team says, let's do some staging. Let's figure out if it's just in the prostate or if it's somewhere else. This has taken on incredibly new and valuable meaning in the last couple of years. It used to be that our staging procedures were okay, but you had to have a PSA that was pretty high before we were going to find anything. And that's out the window now. We're finding disease with PSA levels less than 1. So staging, very, very important. These may include MRI of the prostate to look at the lymph nodes around the prostate and the bones that are in the area of view. It may include CT scans of the abdomen, pelvis, and chest. It may include a whole body bone scan to look at the bones in a more sensitive way. An increasing number of patients are having studies that I've been doing for a number of years now, and those are PET-CT studies to find tumors that are active when the PSA is less than 1. The PET-CT studies will find it no matter where it is. It doesn't matter if it's in bone, lymph nodes, or prostate, or organs. PET-CT will find it. The others are kind of limited as to the organs where they'll find it. Let's look at examples of each of these studies, including how they're done and what information they can be expected to add. Okay, the very first X-ray was done by Wilhelm Röntgen. And you can almost look at this and figure out who he took his very first X-ray of when you see there's a wedding ring on that fourth finger. So yes, it was his wife, and that is her left hand, and that is the very first X-ray ever taken. And that was done in 1895, Wilhelm Röntgen. All right, let's look at MRI. On your left is a normal MRI where both lobes of the prostate show just even normal distribution in white. Okay, and then you move over to the one on the right where it shows that prostate cancer, which is entirely different from the normal MRI. And it uses magnetic fields and radio waves. The patient is exposed to no radiation, and we get a wealth of information. An MRI is best for soft tissue in the bodies. Doesn't necessarily just mean prostate. It's good in the brain. It's good everywhere for soft tissues. What about CT scans? CT scans are really only good for two things. They're real good for the lymph nodes, and they're real good as a problem-solving tool. If we get a questionable finding on one of our other studies, it's nice to do a CT and see something there. But the image on the right with the arrow is pointing to a small lymph node there that would be positive based on its size for a prostate cancer metastasis. So if there are lymph nodes anywhere in the body that are harboring prostate cancer, we would tend to pick them up with a CT because we look at the chest, abdomen, and pelvis. For CT, we use the size to tell us if it's malignant or benign. The problem with that is there's lots of benign lesions that are bigger than the lower limit, than the upper limit of normal, and there are lots of malignant ones that are smaller than the lower limit of normal. So it's not a perfect test, but it's a fairly decent screening test. It does involve some radiation exposure, and it usually involves the administration of a contrast agent, which will help light up those lymph nodes. But that agent is a little bit tough on the kidney, so we need to make sure first that the kidney function is normal. MRI does not suffer from that problem because we don't use a contrast agent which contains iodine dye. Now, the value of CT is a wonderful test, an incredibly wonderful test. We see so much with CT. It's why it won the Nobel Prize, and there's no reason it shouldn't. Here's a CT actually that I was involved in. This was found, there was a mummy found in a trunk in a garage in El Cajon. And they didn't know how long it was there, how it got there, why it was there. And they said, well, let's do this. Let's get a CT of this mummy and see if we can learn anything from the CT. Well, they learned a few things. First of all, this mummy was 850 years old because they could date the bones. And she was pregnant. So they learned a tremendous amount. Just as one example, just a fun example of what you can get with CT. So this is a pregnant mummy from El Cajon. Not a daddy, a mummy. Now, what about the bone scan? Probably most of you, if not all of you, have had a bone scan along the way because it's a very good way of finding disease in the bone at an earlier stage than you'd find it with CT or MRI. Now, in men, if the prostate cancer leaves the prostate gland, 90% of the time it will involve the bone. 50% of the time it will involve the lymph nodes, and 10% of the time it will involve the distant organs. So we do start with the bone scan because, as Willie Sutton taught us, that's where the money is. Okay. Now, this is a normal bone scan on your left where all the bones light up. They're kind of even. There's nothing that leaps out at us. In the middle of the body, you got that circular area of increased uptake. That's usually what a metastasis looks like, but that's just radioactive urine in the bladder. That's supposed to be there. But there are no spots that would suggest metastases to bone in this gentleman. Versus someone here who has a single spot and that's in the pelvis, at the pelvic bone. And that has a fairly high likelihood of being a metastasis, which it proved to be. Now, sometimes it's pretty obvious what we look at, and this is a patient that has hundreds of metastases throughout his skeleton. Now, you can have this many sites of metastases and still have no symptoms at all. So symptoms can be helpful because it kind of focuses our attention, but you don't always have symptoms when it's in the bone. So this is an example of widespread bone metastases. And again, we still have things for treating that, okay? But we need to know it, and now we know it. Now, what is PET-CT, the one I mentioned to you? A PET scan reveals the metabolic or biochemical function of tissues, and these changes take place before anatomic changes take place where we can find them on a CT or an MRI or an ultrasound. But we can find them sooner with PET-CT because the metabolism at the site of metastasis changes first. A radioactive drug is administered. It's a little bit of radiation. It travels through the body and lights up everything. PET imaging is often able to detect the abnormalities very quickly, sometimes with PSA levels less than 1. I've seen them at PSA levels as low as 0.2. So we have to know when to order the test, but sometimes the patient says, I don't care if you're telling me you don't have a great chance to find it. I want a PET scan. So we will usually work with the patient for that. We typically combine the PET scan at the same time we do it with a CT scan or an MRI because the two of them together now give us what is the current gold standard, and that is the PET-CT or, if possible, the PET-MRI. Regular PET scans were on the market from 1999 till 2006. And I brought the first PET scanner to San Diego in 1999. In 2006, out of the University of Pittsburgh, they came up with and perfected the PET-CT scanner, where you had both together. And in the same year, within that year, you couldn't buy a regular PET scanner. Everybody stopped using them because the PET-CT was so much better. So if you're going for a PET scan now for your prostate cancer, you're going to have a PET-CT. There's minimal extra radiation, not much at all, and a tremendous uptick in the value of the study because now our accuracy increases dramatically and we can get much more specific for what we're looking at. I am right now working on getting the first PET-MR system into Southern California so that we'll have that in the not too distant future because that's also a fantastic imaging study, especially in certain areas of the body such as the prostate region and the brain and other areas. And it's also very good for kids because there's no radiation from the MR. So once we put a PET and an MR together, the little kids are going to get less radiation and a better test. So we'll have that in the next year, maybe two at the most. What you see on the left is all those black spots are prostate cancer. In the middle is the CT component that went with it. And on the right, with the blue and the red and the green, is the combined studies which allow us to look at where the hot spots are on the PET and compare them with the anatomical sites on the CT. This is a positive study in prostate cancer. Upper left, you can see the prostate. There's the prostate up here. Down here, we see an area of tumor just in front of one of the vertebrae. Okay, so that's a metastasis. And then if you look at the CT, you can see there's a little node there, and that matches up exactly with the metastasis on the PET scan. And here, there's one on the left pelvic area. You see this right here, and there was a little node there on the CT as well. The next event is to meet with the urologist. The staging has taken place for Mr. Jones. We've got his tissue, we've got his Gleason. He's kind of getting into it now where he's accepting of most of the things, but he's now become an active partner in his care. He is told that he is a candidate for surgery. He's also a candidate for radiation therapy. So he then will try to make the best decision he can with the help he can get and with his research to decide whether he wants to have the prostate removed or he wants to have radiation. He's going to have to go on androgen deprivation therapy because his scan showed a little bit of disease in the lymph nodes. So he's going to have to accept ADT as well as the primary treatment. His physician explains the benefits and the potential risks of each of the therapeutic modalities. He leaves with his wife saying, "My head is full. There's just so much stuff that they're sending my way." And the moral of this line is, if you can go with a significant other, it's very, very helpful because you need another set of ears to hear what you're hearing, because it is a lot of information to throw at you, and these are not things you deal with every day. Next up is an appointment with the radiation oncologist to see if he or she feels that radiation is a better choice than removal of the prostate gland. There's so many things for him to ponder. He's pondering the possibility of being incontinent, of being impotent, of post-surgical and post-radiation complications, how it affects his work schedule, his insurance coverage. What does that urologist say about ADT? There's just a lot to go through as you go through this journey. So let's take a moment to learn about the purpose of ADT in prostate cancer. Now, it's based on the body's testosterone level. Testosterone does not cause prostate cancer. However, it can promote prostate cancer even in small amounts. Hence, the goal is to make our patients with prostate cancer castrate. We want their testosterone level less than 50. That's the magic number so that we know there's minimal prostate going around stimulating the prostate cancer. The most common drugs, as I mentioned earlier, Lupron, Firmagon, and the new oral agent Orgovix. While they're not curative all by themselves, they're going to postpone things for years to decades. And there's some men that really only need ADT for a short period of time and then can come off of it. So it's part of the cure package, but we don't promote it as this is the magic bullet, although in many cases it works like that. They basically work by interfering with the brain to prevent the effects of testosterone. And you've all heard of the pituitary that stimulates the testis to make the testosterone. Well, it actually goes above the pituitary into an area called the hypothalamus. And then it even goes above there, but we're not going to go back to my endocrine training. Let's just leave it with the fact that it's a complicated network that finally gets down to the testosterone. All of these drugs lead to testosterone deficiency. And this can cause impotence, weakness, fogginess, lipids to rise, muscle mass to fall, central fat deposition in the abdominal area, and your bone density can fall. So just like women's bone density falls when they lose their estrogens, men's bone density falls when they lose their testosterone. And yes, that is important, because the last thing you want to do is to break a hip bone, okay? Because that's one of the areas where density is really critical. And the data on adults who break a hip is that 20% of them pass away within a year. So it's very serious when you break a hip. You can have surgery, you can have pinning, you can have conservative treatment, whatever it is, but there is a very high mortality rate just from immobilization and secondary things that come along. Some of the other things that can happen is eye poppage, penile lactation, highness, music overappreciation, proportionate strength and speed of a spider, Swedish citizenship, and the inability to complete a smile album. So a lot of minor complications, but the big ones we mentioned earlier. Now, how about some fun facts about testosterone? Here's a guy with a rat on his hat. These should be memorized because they will be on the post-hoc quiz, so pay attention. Testosterone is produced by the testis and the adrenal gland beginning when a fetus is 8 weeks of age. So up until that time, the fetus doesn't have any testosterone, but at about 8 weeks in utero, the fetus can start producing testosterone, and that's very important for a lot of reasons. As men age, we have something that is very similar to menopause. Ours is called a veropause, andropause, or even male menopause because we lose our testosterone level. So there is a male equivalent. In men and boys, the right index finger is shorter in comparison to the right ring finger, unlike girls, where it's the other way around, and it's a marker for normal fetal exposure to testosterone. This latter fact is also true in rats, and I'm not making that up, and I'm not judging, but that happens in rats as well. And if you're through examining your hands, I would like to continue, if I might. Back to Mr. Jones. He elects surgical prostatectomy, these days almost always performed robotically, and he goes through surgery swimmingly. He does just fine. The robotic surgery shortens the time of surgery, and you also get out of the hospital sooner. That's why we use the robot. Okay, they're precise, very precise, and there's very little collateral damage or neighborhood damage, if you will. Unfortunately, at surgery, his lymph node sampling revealed a number of pelvic lymph nodes that were found to harbor metastatic disease. So it's recommended to him at that point that let's mop up with radiation therapy, let's fry those little devils, and get you on ADT for a period of time and then reassess you in 6 months. So they've got a plan now based on the pathology, not just the prostatectomy, but some localized radiation, ADT for 6 months, and then reassess. It's time for reflection. Upon completion of his radiation therapy, Mr. Jones sees himself as a very different man than when he began his journey. His energy level is down, in no small part from his treatment. He's feeling weaker. He's feeling some of the expected effects after surgery and radiation and the changes due to ADT. He is justifiably uncertain about his future, his mortality, his physical status. He's possibly depressed a bit and worried about his family. These are all normal, natural things that happens to all of us who go through what he went through. It's that letdown phase after you've gone through all the initial treatment with the optimism that you begin to think about, well, what if? And that's a very common finding. That's an important time for the patient and his support groups to be in close touch. Now, with definitive treatment, is his journey complete? No, we just said it isn't complete. He's got other things he's got to do. Sometimes it is complete, very often it isn't. Ironically, his journey may have just begun. Future decisions are going to be made based upon how he is doing clinically, what his PSA is, the results of imaging studies, and the recommendations of his medical team. He will anxiously await the results of each blood test, likely a bone density test to see how strong his bones are, and possible genetic testing and counseling, because there are some genetic indicators of what he should be put on. And that's something relatively new. So there are certain drugs that are available if you meet a particular genetic profile. And that's just a simple urine or blood test that's taken. And so I'm guessing that some of you have had that. There's nothing to it, but it's good information. It also is important because what's going to happen with his insurance policies now that he has had a label placed on him. And so those are going to be additional issues that he will face. This is what a DEXA looks like. Many of you have had them. We measure the bone density in the vertebrae and the spine and in the femur and the femoral neck, because that's what breaks when it breaks. Oh, that's what breaks when it breaks. So we're going to measure the femoral necks and the spine, and we get some numbers, and we compare them to age and sex-matched controls, and we come up with their bone density. So that's very common in patients who are on ADT. Are future tests and therapies guaranteed? Is it mandatory that all have to go through it? Short answer is no, but the longer answer is probably yes. You know, most of us would have to go through additional testing after going through what he went through. He cannot do well for a short period of time and then assume he is cured. It's something that you follow forever. For those of you who raised your hand at the 24-year mark, your evidence that we always kind of keep half an eye on you. The longer you go, the better it is, but it could come back many, many years later, and that's a head scratcher because you haven't had anything for 22 years, and all of a sudden there's an area of prostate tumor. Well, how does that happen if the prostate gland is removed? And the theory, which is correct, is it was there 22 years ago, but now it's activated. And the question is, how does a tumor stay inactive for 22 years and then decide to cause some problems? Well, we don't have the complete answer to that yet, but it can come back decades later. Prostate cancer, as I said, can return years later. Will he need more surgery? No, not likely. It's very unlikely he'll need more surgery at that point in time. Will he need radiation? Probably yes, and we've got a wonderful tool with radiation therapy now, so we can locally radiate or radiate almost any of the body many times over. Will there be changes in his drug management? Probably so. When do we need to do further testing or to restage the gentleman? If he develops symptoms, if his PSA rises or it rises quickly, meaning a short doubling time, or there's a contemplated therapy change. And do we then need to consider immunotherapy with Provenge, chemotherapy with Taxotere, targeted bone therapy with Xofigo, peptide receptor radionuclide therapy with Pluvicto, additional radiation, referral to a center with more experience, clinical trials, or even a pause in treatment for both physical and mental reasons. And that's what I said at the very beginning. There's just a ton of things that we can do, okay? We're not going to dwell on any of these, just to let you know it's pretty hard to run out of arrows in our quiver for each patient, okay? We have a lot, and it depends on the individual patient. With this panoply of choices, most men and their physician opt for imaging choices when they reach a certain point because the imaging is so good now. Let's examine the options for imaging. You can do the PET-CT we talked about. Excellent, excellent test. That's what we're doing now, is PET-CT in all of these gentlemen. Other studies to look at bones, for example, we have bone scanning agents we can use. And we've got 3 agents now that we can use that are the PET-CT agents. The brand new one on the market is Posluma, and that's not too terribly different from the Polarify that I like. Posluma may have a minuscule advantage in the bladder area. You may not see as much bladder, but other than that, there's not a lot to choose from them. And you're going to find these days that typically posluma may not be covered yet by certain insurances. So no reason to go searching out that one because the statistical evidence about is it better is not there yet. So, but we do have 3 now that can be used very nicely. To look at the non-osseous sites, non-bone sites, we can do CT as we talked about. We can do MRI, which is a problem-solving tool for inconclusive studies and to look at soft tissue. We can do PET-CT. And often more than one modality is necessary. It's not uncommon to need a couple of them if we're having a little bit of trouble finding this because we're looking when the PSA is very low. Now, you don't have to remember this, it's actually not on the test, but if you have had a prostatectomy, the prostate is gone, and if we measure you and your PSA is measurable, and then it can be measured again, and if it's measurable, that's an indicator that there's something going on, probably a little bit of prostate cancer tissue somewhere. Okay, so you need 2 PSA measurements, both being positive, separated in time, before we get nervous about it and start looking into it. Because sometimes you can, for whatever reason, you can get a lab error or something where it goes up a little bit. Next time you check it, it's 0, and then it's 0. So that's for a prostatectomy patient. For a radiation therapy patient, post-radiation, their PSA level has to be greater than 0.2. And the reason for that is because some normal prostate tissue was always left behind, a little teeny bit. And that can make enough PSA to get it up to 0.2. So we don't jump off a bridge when the PSA is 0.17 in someone who's had radiation. It could just be some normal tissue that's left. That's for me to know, but you to just hear that there are specific ways we look at the PSA after primary treatment. Uh-oh. Not moving. Am I doing something wrong? Probably.
I think something got touched here is all. Is that the next one?
Okay. Thanks. You sure you're gone in June? I'm not back. So I say, you sure you're gone in June? It doesn't matter. I won't be back. So. Anecdote alert. MRI was created in 1981. And the very first meeting about MRI was in Houston, Texas. And at that time, no one was sure who was going to get to read the MRIs. Was it going to be the radiologists or was it going to be the nuclear medicine physicians? Because believe it or not, the name of it back then was NMR, nuclear magnetic resonance. So here comes the turf battle. The radiologist who deserved it said, this is radiology, we should be reading these, because everybody knew this was going to sweep the world, MRI. And then nuclear medicine physicians, all 14 of them, said, wasn't quite that low, but there weren't many of us, said, not me, said, no, this is NMR, this is nuclear magnetic resonance, we should be able to read those. So thankfully, sane heads prevailed, and it went to the radiologists, because they're the guys you want, and gals, you want reading your MR, not some hamburger like myself. You know, I can look at them, and I can see things in there, but not like they can do it. So I'm riding back to San Diego on the airplane, and I'm sitting in an aisle, and there are a lot of us from the conference in the plane, and there was 2 radiologists sitting next to me. And we made pleasantries and introductions, and we're heading back, and we get out an hour or so, and we're kind of napping, and I needed to go up and use the bathroom. So I told the guys, I need to go use the restroom, but do you like anything? And they said, hey, yeah, we'll have a Coke. So I paddled on up. I left my shoes there. We were close to the front. and came back, gave him each a Coke, and sat down and put on my shoes, and the toes in the right foot the toe was soaking wet. It was obviously filled with saliva. And I didn't say anything, so they pulled a good prank on me. Okay, it was just a joke. We got about an hour out of San Diego, and the same thing happened. I said, I'm going up to the bathroom again. Do you guys want anything? Hoping they didn't. And they said, yeah, get us another Coke. That was nice. So I come back, sit down, put my foot in, same thing. The other shoe soaking wet at the toe. And at that point, I still want to be a nice guy, but I had enough. And I said to them, I know we're competitors, and I know there's a little tension between the two specialties. But all of this spitting in shoes and urinating in Cokes has got to stop. Here's a 70, and I'm just going to show you a few PET CTs and we're done. This is a 77-year-old male, and there's a spot right by his iliac bone. That's how small a spot we can see. This is in a single rib. Okay, no test showed this, but here it is in a rib, and it's one spot. So you can just radiate that, and you'll kill it. And then the hope is that since it's the only spot that was identified, maybe that's the only spot the patient has, and he still is in the cure bucket when we see one site like this. Here's another spot near the liver. That's the liver, normal amount in the liver. That's another spot there. And that, we weren't sure, well, where is that? I mean, it's kind of in the middle of the body, but when you put the CT on next to it, you can see that this is the vertebral body right here, and it's right in the top of that vertebral body. So that's in bone, also can be radiated, no problem. Again, this is the prostate gland, where you see it way down here in the inferior lower part of the prostate gland. Here it is again in a lymph node in the pelvis. Here it is where you say, well, there's the bone. That could be a lymph node, that could be a lot of different things, but it turns out it was a lymph node, and that was a metastasis in a lymph node, an enlarged lymph node, easy to radiate. And the radiation therapists are very willing to shoot you at 5 or 6 different spots at one time. And that's kind of the number they pick. If you've got less than 6 sites, they'll go ahead and radiate for you. Okay, they're happy to do that. There's one in where the seminal vesicle resides. And the seminal vesicle resides in the top of the prostate. So that left seminal vesicle is involved with cancer. And this was a study done before he had any treatment because the patient was what we considered high risk. I'm not going to bore you with all the things that made him high risk, but they did a PET CT scan and they showed that. But we also get good news when we put the two of them together. This was done first, PET scan, and they said, well, this part of the vertebral body is all white and sclerotic. That's probably a MET. So we went ahead and did a PET CT, and it didn't take up anything. So that's an area that was a metastasis that's now healed. So there's nothing to do for it because it's not metabolically active. And this is a gentleman where you can see it again in one of the vertebral bodies at T11, the 11th thoracic vertebra. This one she's got the positive arrow sign. You can see it there in a rib on the side there. Past that. One more here. You can see that the patient had radiation for his prostate cancer, but then he's got activity in one of the bones up in the chest, and he's also got it in the lymph nodes here. Here it is on CT, in what we call the mediastinum up in the upper chest. So enough of those, but it just shows you how accurate these things can be. Time out for a brief summary, and then we're done. So Mr. Jones has arrived at a decision point. His path has included primary therapy with a robotic surgery, radiation therapy, and ADT. Because his PSA continued to rise, and that makes him castration resistant, he was placed on second-line oral therapy oncolytics. And there's a whole list of the second-line treatments. You've heard of them. The ones you've heard of most, I think, are Zytiga and Xtandi. But there are others that we have. Apalutamide is Erleada, darolutamide is Nubeqa, and he can also be a candidate for a number of other things. But oral oncolytics work very well. And he was placed on the oral oncolytics. His PSA fell and then rose again. And this is common in prostate cancer because there were some cells that were resistant to the oral oncolytics. He was therefore restaged with whole body scanning. He's now sent to meet with his medical team to discuss the advanced things we talked about: immune therapy, chemotherapy, second opinion, perhaps a clinical trial. All these things are available to him. And many options remain. And there's all the different options, including the newest options, which we're doing a ton of at the university. One of them is Pluvicto. It's a radioactive agent that will wipe out the metastases, does a real good job. It's a 6-course treatment, 1 minute per treatment, that attacks the cancer. And there are others, immune therapy type drugs and genetic drugs. And at the rate at which these new agents are becoming available, the aforementioned options will definitely continue to grow. So he's gone through a lot. He may still need to go through more. Those options are there. So what's next for Mr. Jones? Armed with many additional therapeutics options as well as imaging studies with higher levels of accuracy, he can realistically remain hopeful that whatever he chooses will be successful for some period of time. So many men with advanced prostate cancer like Mr. Jones will continue their journey relying on advice of their medical team and the knowledge that newer studies and treatments are appearing rapidly. Does the journey end here? Absolutely not. As with many of our patients who have castrate-resistant high-grade prostate cancer, Mr. Jones may ultimately run out of viable options. You know, he may have tried so many things, and what is left we know won't work for him. And it happens with all medical illnesses. Sometimes we reach a point where we feel we've offered all the benefit we can offer without making the risk too high, and he may have reached that point where the risk outweighed the potential benefit of things that we had left. So enters the art of medicine. And this includes the physician who promised never to abandon Mr. Jones. This is an oncologist that I know who tells everybody the first time he meets them that he will be with them through every step along the way. He will never abandon them, no matter what his medical situation, and to call on him whenever he needs anything. And I always thought that was a very nice and reassuring thing to say in the beginning. His primary care physician is urologist, his medical oncologist, and radiation oncologist. The local prostate group, so you can be with folks who know what you've gone through, and so many of them have gone through it themselves, and among others. And these things will be those things which offer him support, hope, and optimism. If Mr. Jones chooses comfort care, he will have many nurturing and caring experts to walk the remaining journey with him. That's all part of what we should do and what we do. So we will never abandon our patient. We just might have to look in a different direction. Thank you, and please do not wake the person next to you. Would anybody like a Coke?
Thanks a lot for a wonderful presentation once again, Doctor. Before we get to some questions from the audience, there was one thing that I just wanted to clarify that you were saying earlier on, where you were saying that Gleasons of only 6 through 10 are considered now, and that was referring to the sum total. So when we say that there's a Gleason 3+4 or something like that, that's a 7. So we only talk about Gleasons 3+3 through 5+5. So, okay, any questions? Let me bring the microphone around. It helps for our video recording so that we can hear you on the video.
In reference to the bone density test, would you recommend, and probably you would, some medication to strengthen the bone? And if so, what do you believe would be the best drug, or in your opinion?
Yeah, there are two recommendations. If you are a patient who has no metastatic disease, the drug of choice is Prolia, which is given once every 6 months. If you have metastatic disease, the drug of choice is Xgeva, which is a denosumab, and that is given every month or two. And the reason we use that for our folks with metastatic disease is not only is that a drug which will help the bone density, it actually has some anti-tumor effects. So those are the two you want to use. Now, that being said, decisions are often dictated by the insurance companies, and there are a couple of other things that can be given for low bone density. But I don't want to get that deep into the woods. The bottom line is for 98% of you, it will either be Prolia or Xgeva.
And one thing I want to add about that, from my mom's experience of being on, what was the first one you mentioned? Prolia. Do keep track of your calcium levels in your blood while you're on that, because my mom's calcium levels dropped to 0, and she developed all sorts of other side effects as a result of that, because the calcium that she was taking orally was not being absorbed. So something to be aware of. There was a question here.
The treatment with Pelafri maybe works 1/3 of the time, improvement, another third holds things, and a third completely doesn't work. How do you evaluate which patient should receive the treatment?
And did you say with Pylarify?
Yes.
The injectable that we're using, like the Pluvicto?
Yes.
Yeah, there are 2 or 3 things that we look at with our patient. One thing we look at is the PSA level, and although it's not uncommon to see slight rises and falls, significant rise or fall in the PSA is a good indicator that either the patient is not responding if the PSA is going up during treatment, and the patient is responding if the PSA is falling. The other thing that we can do, and we're actually helping to gather the data on this now, is we ask our patient to come back once or twice during their course of treatment, and we take a scan of them, where we just lie them on the table and spin the camera around and take a scan, and we look for any changes on the scan. If we see new sites, they're not responding. If we see sites getting less intense or disappearing, they are responding. So PSA and scanning after the injection are the 2 main things we use to look at. And we can get a pretty good handle on who is and who is not responding.
More questions, right here.
When you mention nuclear medicine, what does that include?
Nuclear medicine includes all radioactive materials that are injected into the patient to look at things in a way different than regular radiology. We don't shoot beams through you like regular radiology. We inject a little radiation that will go to a specific organ, and then we look at the function of that organ.
Why is it that estradiol, low-dose estradiol supplementation isn't used for men to avoid hot flashes while on ADT and to avoid bone loss?
Well, there are going to be side effects from that. And are the side effects worth it? I mean, you're going to want to shop at the mall. No, there are the potential for side effects from even low-dose estradiol, not the least of which is a slight increase in your risk of having thromboemboli. And we just don't feel that that's the way to go. It's also known that the human body can convert estrogen, the male can convert estrogen to testosterone, and the female can convert testosterone to estrogen. So there are hormonal changes that could take place in the wrong direction if we put them on any type of hormone.
More questions? Who's next? I'm sure you must have some.
Are you still with Genesis?
No, I'm at UCSD, and I still am in contact with the folks at Genesis, and I still do some of their patients for them, but I'm 90% of the time at UCSD.
All right, last call for questions. Keep them up, that's fine.
When is it worthwhile to do a combination of different types of PET scans in addition to a PSMA PET, a metabolic type PET scan?
Well, that's a very good question. There are two main types of PET scan that we have in prostate cancer. The first is the PSMA, which is the one we use in most of our patients because most prostate cancer cells, fortunately, are not very active metabolically, okay? And PSMA works very well for that. I mean, they take up the PSMA, but they won't take up our other agent. And if we do the study on someone in whom we feel they have metastatic disease and the PSMA study is negative, because it is positive 95% of the time, we start to think that the cancer cell that that patient has is a different animal and that it's become what we call a neuroendocrine cancer cell. And they then will show up very nicely on our standard PET scan with fluorodeoxyglucose, FDG, which is what we use in all other types of tumors. So we would then go to that second type of scan if the first one is negative. But the first one is so good, at such a low level of PSA, we always start with that one now.
Excellent. Oh, another one.
So, I don't know how many, last year I was diagnosed with low-density bone, and I was just trying to find out the name that I take. So I take a pill once a week. It's called, I guess, Flussamax. Mm-hmm. And so that's, at Kaiser, they have me with bone management. So because I'm on, I've been on Lupron for almost 10 years. Mm-hmm. And so a few years ago, I fell and cracked a rib, and then like a year later, I fractured, and when I cracked the rib, that's when they tested my bone density and found out that I had osteoporosis, and so that's when they put me on the Flussamax, and then also increased my calcium. So I'm taking 6,000 milligrams of the calcium tablets. So,
well, now that you've violated your own HIPAA regulation and told everybody you have osteoporosis, do you mind or do you know what your T-score is?
my
T-score?
Yeah, my testosterone score. Yeah, it's like the last time I was checked was 8.
No, that wouldn't be it. Yeah,
What?
it's okay. Fosamax is the most commonly prescribed drug in gals because it's a good treatment for osteopenia and osteoporosis. We just found that we think that there's a better response to the Xgeva and Prolia than there is to the Fosamax. So most places that deal with prostate cancer put their patients on Xgeva or Prolia.
Yeah, that's just what they put me on at Kaiser. That's what they found. I don't know. I mean, that was the only option that I was given. So,
Yeah.
But I'm switching over. Actually, next month, I'm switching over from Kaiser to the VA hospital. Mm-hmm. So
They may change that. The other thing is you are entitled, as all of you are, to a repeat DEXA every 2 years. And if the next DEXA you have shows that you have been improving on the Fosamax, you probably don't need to change it. But if you're continuing to lose density and you've been a good citizen on your Fosamax for a while, they'll need to switch you to something else.
okay. Thank you.
Sure.
Yeah, I took one of these Dexes, and they're trying to get me to take the medication now for a few years, and I looked up all the side effects, and I get acid reflux, and I've tried Fosamax and the other stuff, and then I looked up, is it Beniva that you take it every 6 months?
Beniva you can take a little less frequently.
Yeah, when I saw the side effects of that, I said, my goodness, I'd rather go with osteoporosis. So I'm just doing everything I can and keeping off these medications because they seem worse than whatever I've gotten. I just watch myself and lift weights and stuff like that and just take my chances.
Yeah, I don't know why you might not be a candidate for one of the injectables where you wouldn't have to worry about that reflux and some of those other things. It might be worth telling your doctor, look, I can't take those. I've demonstrated I can't. Is there anything I can take that is an injectable? And there's some things that you don't need to take as often as you would have to take the Fosamax. We don't want you to break a hip. No.
I understand that UCSD is using AI assistance for reading MRIs. Is AI being used for PET CTs?
It's looked at. I mean, it's being studied, and I think that there will be a place for it. The point is there's the science of medicine and the art of medicine, and you've got to be pretty experienced to get a good reading on a PET CT, and we don't know if AI is going to be able to do that yet. And we don't know if AI is going to be able to offer a differential diagnosis or just say there's uptake in the right femur and kind of leave it like that, where we can usually tell by putting everything together what that uptake means. So I think there's absolutely a future for it, but we're not there yet, certainly not with PET CT.
One other question. I understand some manufacturers of PET CT machines have more advanced generations. How much value is there in seeking out the newer generation PET CT machines that are more sensitive and precise, possibly?
Well, the good news is the three major manufacturers, the PET components are equivalent. There's really nothing to worry about. When you get to the CT component, what you want to have is a CT with the highest number of slices, they call it, slicing the body, or rows, they call it. And if you can get to one that's got 32 or more, typically 64, that's probably a better machine. And most of the bigger places around will have the good PET CT systems. Now, a PET scan takes about 20 to 25 minutes once you lay down and the cameras do their spin around and do all this stuff, and there's a certain amount of radiation. If I had all the money in the world, and if anyone wanted to donate, that would be fine, but it's a $10 million price tag. There's one that they've developed up to Davis, UC Davis by David Cherry, that is called a whole body PET CT scanner, where you lay down and it does a whole body very quickly. And I looked at their images, and their images at 20 minutes were the same as their images at 1 minute, and their images at 20 minutes were really not much better than at 37 seconds. So they have machines that in the future are going to knock the time from 25 minutes to 1 minute, which is an incredible advantage for we need less radiation injection. You need to be on the scanner less time. Kids can go on it and we don't have to sedate them, because that's a pain in the you-know-where, because a lot of kids need PET studies. But if they're only in there for 37 seconds, that makes that a lot easier. So the advances are occurring in cutting the time and radiation dose down, but all other PET CT scanners are pretty equivalent now out in the real world.
So if you're looking for oligometastatic lesions for treatment with radiation therapy, and you want to get as sensitive as possible to find everything that should be treated, you feel there's not an advantage?
Yeah, there's not. You cannot go wrong. You can go to Scripps, you can go to Sharp, you can go to UCSD, you can go to so many places. The outside places, imaging healthcare specialists, they all have state-of-the-art systems that can give you the same technical information.
For such a miraculous machine, let's get those baskets back out here and spread them around again. I'm sure we can come up with
I
that.
feel guilty going into that basket twice, though. I took a little.
Just don't piss in the basket, all right?
Oh, no.
I mean, given that my 7-year-old had to be sedated twice, and that was, very scary last year when she had encephalitis, that just sounds like a miracle machine.
It is.
Yeah. Wow. And I know that life scans or something now are being marketed where people that don't even have any symptoms or whatever are basically just told, yeah, for $2,000 we can scan your whole body looking for cancer. Somebody raised the question, well, why don't we all do this? And it's like, well, how many machines would we need for the hour or two required for doing that? And it's like, well, this is, cuts down the price of doing a CT by an order of magnitude, because now you can have 10 times as many patients or even more.
You could, and I'm as entrepreneurial as the next guy, although I don't know anything about it. But I've never been a fan of screening, because I think the two things with screening. First of all, you're exposing the patient to radiation which they don't need. And secondly, with screening, and they've done this study, they did it in Japan with 8,000 patients. The number of sites they found that were true positives was much less than the number of sites that were false positives. So then you got this great group of people that are worried, have to go through additional tests. They didn't really have any disease, so I'm not a real advocate of just screening people willy-nilly.
True. Okay, we're gonna give you a prize for most questions this time, Terry.
Considering that, is there value in having a baseline reference scan, like at a low PSA, for comparison when you get another PSMA PET scan in the future at a higher PSA, so you got an A-B comparison to spot things, so you won't have false positives, you can see growth or a change?
The short answer is no. The longer answer is we are now allowed with the new agents to do a PET-CT, which will be covered by insurance, if at the beginning of their evaluation they are determined to be high risk. What's high risk? High PSA, short doubling time, strong family history. There's a number of things that would make them high risk. You then should have one before treatment, because what if you didn't have one and you go through a prostatectomy and or whatever else you go through, versus having had it as a high-risk patient, and they show that there is 5 different lesions throughout the body. You may not have been doing the patient a favor taking out the prostate gland and then watching them and let that stuff spread. So on the front end, we can now do it in patients because it's recognized it's of benefit, but I don't think everybody needs it unless there's high risk.
What about somebody who is recurrent and currently low PSA, but rising PSA?
Oh, no, they should have it. That's absolutely an indication. Their PSA gets anywhere above 0.5 to 1, they should have it.
How about if it's been a couple of years since you've had therapy, and since you've had imaging at all, and the doctor wants you to get new imaging to check to see if there's anything unusual going on?
Yeah, no, you want PET-CT. Yeah.
Versus a bone scan and a CT scan?
Bone scan
Better to get
typically
a PET?
needs a PSA level of about 10 to 20. CT, again, it's up in that range. MRI just looks at one little area. Wouldn't you want to know that your whole body was clear, or that there was things here, here, or here that needed to be addressed, and not find out 6 months down that instead of having 3 sites, you now have 14 sites? And I know you were asking questions just till you got a right answer, so I'm waiting until we got you all covered.
Oh, another question back here.
I don't have a question as much as a comment or something you might speak to. I got a biopsy 11 years ago. I've been on active surveillance. And I recently got another biopsy, and it was a transperineal biopsy. And I was wondering if you could speak to the people here that that's a viable option, and it was a lot easier as far as pain getting that, and I got it at UCSD.
Yeah, I know that that is an option. I can't speak intelligently about what the data are, that they're the same end result. I suspect they would be, and I suspect in someone like yourself, who's 11 years out, that that would be quite satisfactory. If it was someone that was 2 years out and there was additional concern, they might want to go the old method. But that's a reasonable thing to do in someone that's kind of low risk.
And I believe one of our prior meetings had a lot of details on the transperineal biopsy. So check the website, check YouTube, and look for that information if you're interested. Any other questions? I think we've tired out Dr. Kipper. He's sitting again. And with that, I think we're just about done. But first, I did want to clarify, we are in fact back here for meetings on the third Saturday in June. Only May is canceled. So with that, please enjoy a little light lunch. I'm sure Dr. Kipper is happy to take more questions too. Thank you.